Let's review the principles of perianal Crohn's disease involvement and management. All right, what is perianal involvement in Crohn's disease? It includes skin tags, ulcers and fissures, and then fistulas, abscesses, and strictures, which tend to happen together. A fistula itself is a tract, so the issue with the fistula is drainage, soiling, not necessarily pain. However, if an abscess is there, because of the sensitivity of that area, then it could be the most painful complication a Crohn's patient could have. And it's not always visible to us on exam or even elicited with palpation. So my advice to my fellows is always believe your patient. If your patient with Crohn's disease presents with perianal pain, you have to look for an abscess. You have to image. The principles of managing the perianal fistula that is complicated by an abscess is relatively straightforward. Manage the pain. Again, one of the most painful complication that a Crohn's patient could have. So oftentimes IV short-term narcotics are needed. Drainage, get the pus out, get your surgeon involved immediately. And you can use antibiotics intravenously for a short period of time or orally if the pain level is managed by oral pain medications at home. The thing about antibiotics is they can help treat the sepsis. They might help temporize the fistula. But long-term success rates with antibiotics is very, very low, and recurrence rates are very high. After you treat the sepsis, if there is a stricture, this is a driver for recurrence of the fistula. This should be addressed. And then the Crohn's disease, that is the main pathophysiology underlying the fistula formation, should be treated effectively. Now, if you treat the inflammation, you drain the abscess, your patient is doing well, but has a persistent fistula, then you look at the options to close that fistula beyond treating the inflammation. Once you have the abscess drained, the next question is, how do you treat the inflammation that led to this? And based on the consensus guideline, and perhaps actually the strongest data that we have so far, using an anti-TNF agent plus or minus immune modulator is the most effective way to go. The main thing that the surgeons help us with is drain the pus and help us define the anatomy of the fistula and place the seton. The seton placement is in principle to keep that tract open so as you treat the Crohn's inflammation, you don't get that tract clogged and you don't allow another abscess to happen. So this is the concept behind keeping that seton, non-cutting seton drain in. In summary, it's a very essential point to take care of for your patient with perianal disease, and then we need more and more studies to know what to do from randomized controls data, and then expect more data from promising treatments like stem cell therapies. Thank you, Dr. Lee.
The case that we discussed is a 22-year-old female with Crohn's disease diagnosed about a year ago, currently on monotherapy with infliximab, 5 milligrams per kilogram, presents with perianal abscess. MRI on pelvis shows 2-centimeter abscess with 2 fistulous tracts, one simple, one complex. Next steps.
So obviously there's an abscess. First thing I want to do is treat my patient's pain, call my best surgeon who's experienced in examiner anesthesia and drainage, treat with antibiotics, IV short-term, and then once the pus is drained, whether we have a seton or not, start early combination therapy of thiopurine and anti-TNF.
I love that Jerry Maguire movie, that we complete each other when it comes to perianal abscess management. Like really, that this is very, very critical. It starts with you, but this is something we as surgeons absolutely need the medical therapy here. That Crohn's is not surgically curable, we know that. But if it comes that some of the parts of the Crohn's that is absolutely not curable with the surgery is the perianal Crohn's disease. So anytime there is a fistula, I don't think it hurts just to have the initial interaction to complement each other and also helping each other, specifically with all these biologics and everything, the experience that I have most of the time, our gastroenterology colleagues would like to make sure that the issue is really well drained, cleaned, so the proper therapy can be started. So I would make this a more of a generous relationship when there's a perineal presentation, just to say hello at least to start with, potentially complemented with the exam under anesthesia, cleaning up, and the further therapies that we may talk.
Any of our other colleagues, before we have a couple of questions from the audience, and I wanted some clarification on our ARS questions, but Fernando, Gil, Brian, anything to add right now?
Two things I would just point out from this case. One is that this fistula looks like it arose while on infliximab. So that's something that I think needs to be dealt with, if that's true. The other is just a general point about antibiotics. Our surgeons actually prefer that we not use antibiotics and are very much against the use of antibiotics. I'm just curious about the role of our use of antibiotics before we send them to you or before we have that initial conversation.
For the initial presentation, I think it would be nice. Draining the abscess is very critical. If the people use it just by the time they get there and everything, I have no objection. But I think timely these patients being seen,
Sure.
especially they have pain and everything, because this is a very humbling pain to deal with. So most of the time, this is, in my opinion, a surgical emergency.
Right.
But on a continuous basis, you guys are much smarter than me. You know the reaction, how it works. But I think the antibiotics also has some benefit, complement the biologics with some healing rates and potentially the cooling the things
Yeah,
up.
we do have one controlled trial that does show benefits. I'm a bit surprised at your surgeon.
Yeah, Gil, can I ask why? I mean, unless there was an adverse outcome, or, I mean, when you culture these things, they're just
Yeah,
gut
sorry,
form.
perhaps just to be clear, I'm talking about this case,
Mhm.
using antibiotics. Let's try antibiotics before we send you to the surgeon. The idea, I think,
In lieu of.
is brought out is this could be a surgical emergency. Somebody presenting with an abscess, don't use antibiotics for a couple of days to see if it works.
Right.
Send them to surgeon immediately. It could be an urgent need for a
Okay.
drainage procedure.
Okay.